Welcome to Session I of the SQA September virtual meeting. My name is Teresa Donegan, and I will be the chair for your session. Today's presentations include maintaining the validated state of your equipment and processes during the COVID-19 pandemic to ensure continuous product supply, presented by Geraldo Gomez. Expansion of UT-MB FDA education collaboration, data quality and integrity in clinical trials involving high consequence pathogens, Melissa Eitzen. Data integrity validation, a new approach, presented by Richard Siconolfi. The presentations in this session have been pre-recorded and will be broadcast in order. Please note that some of the talks and some of the presenters may have been changed up between the time of this recording and the actual meeting. At the top of the screen, you will see a list of speakers for the session. Please click on the speaker's name to view their profile and read more about them. The presentations today represent the presenter's opinions and not necessarily those of SQA. You can submit questions and share comments throughout the presentation using the chat function. If you click on the chat button on the top of the screen, it will open up a box at the bottom of the screen where you can enter in your questions and submit them. The presenters will do their best to respond to questions via the chat while the presentation is being broadcast. If there are several unanswered questions at the end of the process, the presenters will provide a written response after the virtual meeting has concluded. These written responses will be available along with the recordings and the slides. There will be a brief pause between the time of presentations, between the sessions. Once all of the recordings have been finished playing, the session will end and there will be a break before the next one begins. Be sure to consult the schedule to confirm what time things will resume. Recordings and slides have been released by the presenter and will be available in the on-demand tab in the virtual platform. You can view these recordings at any time. During the breaks between sessions, you are encouraged to visit the exhibition hall and also visit the virtual posters that are there as well. We have a prize drawing for 30 points for visiting each booth or poster. Once you've earned 450 points, you'll be entered in a drawing to win an Amazon gift card. Thank you for joining us for this session. The presentation will now begin.
Hi everyone, this is Melissa Eitzen. I'm here from sunny Galveston, Texas, and thank you so much for joining me today. And I'm going to share my screen. And as soon as I get this started. Okay. So I'm here today talking to you about the expansion of UTMB's educational collaboration program with the Food and Drug Administration, and specifically the addition of a course addressing clinical research trials involving high consequence pathogens. This is funded by an educational grant, and you'll see in the bottom right-hand side of the corner, I have put our grant funding award numbers there. We have an award in 5-year increments. And so we were awarded our second 5-year increment in 2017. So therefore, you'll see there are 2 numbers there. I have provided the abstract here for your reference. And today I really want to talk about 3 things. First is the background. And so you have a little bit of context with our educational partnership with the Food and Drug Administration. And then we'll go into the course development, lessons learned, and finally end with a slide talking about our future plans. So we have to begin by starting with the animal rule. And that was published in May of 2002. And that's when FDA decided to amend its new drug and biological product regulations. And I have it circled here for you on the slide. And this allows appropriate studies to be done in animals. It's very specific. And when this is allowed, and FDA has to make that decision, not the sponsors. But this rule will apply when adequate and well-controlled clinical studies in humans cannot be ethically conducted and field efficacy studies are not feasible. inside of this animal rule, which is what we've referred to it now, the animal rule, actually in the supplementary information in the introduction. So it's not within the regulations, it sits outside and before the regulations, and I've circled that here for you as well. It says that all studies subject to this rule must be conducted in accordance with pre-existing requirements under good laboratory practices, or 21 CFR Part 58 regulations, and of course the Animal Welfare Act. And to address this GLP in high containment or maximum containment laboratories, because our research community became a little bit up in arms about how do we do this. Obviously, there had been some BSL-3 done in BSL-2 laboratories, but not necessarily so much in BSL-4 laboratories. And I'll talk in a minute about what the difference is in 2 and 4 laboratories. But what happened was the FDA approached UTMB, and they decided to work with us to develop an academic program or training program, educational course, for how to actually conduct GLP studies in high containment laboratories. And this was also published in the Federal Register, and I've put a copy of this here where they announce its intention to do a single source funding stream. And just to give you a little bit of background here, and I pulled this from the CDC website, and the link is there as well. When you're talking about biosafety level laboratories, they go from low to high risk, so from 1 to 4, and a BSL-4 laboratory would be those that deal with the highest risk microbes. So in the beginning, we decided we designed a course to address these animal rule studies for the non-clinical labs that were doing these animal rule studies. And we called that course Achieving Data Quality and Integrity in Maximum Containment Laboratories. And we used the ADDIE model for instructional design. And I've shown a diagram here. And basically there are 4 steps. You do a market analysis or a gap analysis needs assessment first to see what your educational gap is, what those needs are, and then you design your course around meeting those actual needs. You develop that course and implement it, and it does, you evaluate that entire process while it's ongoing. And the idea of that being that you do a continual update of this educational activity. So it's an ongoing process. So your course evolves as your need and your gaps evolve. We did a pilot course in 2013 to test that. We have an online GLP as a partnering course. It's offered annually. There are no registration fees. The grant covers that. And we had our first 5-year funding period. We renewed it in 2017, so we still conduct that annually. And from 2013 to 2019, we actually had 355 attendees attend the course. So these courses are relatively small. There are about 40 to 50 in each of these courses. We consistently have positive evaluations, and every year we have a wait list to take the course. Throughout this, then, we saw the product development under the Animal Rule Guides for Industry evolve, and this is a 50-plus document now that started out as a 9-page concept paper and now is an approved or a finalized guidance document. And within that, it now states that the FDA recommends the use of the FDA regulations to the extent practicable to ensure the quality and integrity of the data of these studies. So our research staff go, wait a minute, we have to do the GLP regulations. And yes, that means you have to do them to the extent that you can. And then the quality assurance personnel go, wait, is this GLP-like? And so you can see the shock look on a lot of our faces. But it really does mean that we need to follow GLP as closely as possible, because that is a quality system that ensures the quality and integrity of the data. A couple of definitions there that FDA uses. They're also contained within the guidance document that I have shared with you as well. So what about clinical research trials? Well, I posted an article here. There are several, but this is a really good article about Prevail-1, which is the partnership for research on vaccines that were done in Liberia. There were actually more than one Prevail. There's Prevail-1, Prevail-2, et cetera. But this one really talks about Prevail-1, and it really addresses the conventional wisdom of doing clinical trials and then dropping those into Liberia for vaccine development for the Ebola the Ebola virus disease, and conducting randomized blinded placebo-controlled trials. This was a very difficult thing to do. It was a very large studies. We dropped those into an infrastructure damaged from the Civil War. It was a short ramp up in terms of it being less than 3 months. So there were a lot of lessons learned. There were a lot of assumptions there and then lessons learned. And it was very successful, but there was a lot of change involved and a lot of lessons learned. So it's a very good article to read if you'd like. I have a link provided there and also at the end of this presentation. So in terms of a training gap and an educational need, we learned that the current surveillance and data collection systems are not necessarily designed for the purpose of assessing safety and clinical benefit during a public health emergency. We also learned that clinical trials conducted under barrier nursing have increased challenges and obstacles for data collection, retrieval, and management. We have to be very creative in those fields. And then those creative approaches we take in order to assure data quality and integrity for clinical trial sites involving the high consequence pathogens or the barrier nursing environments. So to go back to then the development of the clinical the clinical course using the ADDIE model, we first have to do a needs assessment and gap analysis. And we do this through literature searches, market analysis, and really engaging our stakeholders. And we did that through the needs assessment and also through that gap analysis. We also then do an initial development based off of that gap analysis and needs assessment, where we actually have the educational goals and the learning outcomes that develop from that. And then we identify our subject matter experts, our topics emerge from that. We identify faculty that can speak to those topics, decide what length the course should be, what platform we should deliver that education, what our overall objectives for the course should be, as well as the individual objectives for those topics. And then we test that all and evaluate that and actually test the knowledge gain in a pilot course. So we started with actually a face-to-face meeting then after we did our literature search with our stakeholders. And I've listed some of the stakeholders there, but we engaged the entire regulatory, research, clinical, military, international community. And we had about 50 people attend this. And our overall goals then for that was to analyze existing educational opportunities to support our educational need, identify specifically those gaps and develop potential course topics, identify our subject matter experts, identify our target audience for the course, and develop an initial list of potential course faculty. And on the next few slides then, I just want to list those top four that came out of this workshop in terms of generalized identified needs, that then the results that the course would address, and our learning objectives. So the first one that came from the stakeholders meeting was there was actually a lack of consensus on how to design and implement these research clinical trials in an international setting during an outbreak involving high consequence pathogens. You can actually see some of that now playing out with SARS-CoV-2 and the COVID-19 disease. Our desired results were to develop best practices for the design and implementation of these research clinical trials during the outbreak. And our learning objective would be to formulate solutions to regulatory, operational, and cultural challenges for the conduct of these clinical trials. Our next identified need was what we decided that there was actually a knowledge gap of clinical staff regarding the implications of incomplete documentation on research outcomes. So our desired result was really for our clinical staff to recognize that and to prevent the potential risk to data quality and integrity if we have those potential gaps. Our learning objective then would be to identify best practices to mitigate these risks, to reduce these risks to data quality and integrity. Our next identified need then is to limit our limited experience in the conduct of research clinical studies in biocontainment and barrier nursing environment following good clinical practices. Our desired result would be to apply these GCP principles to clinical research studies for medical countermeasures of of medical countermeasures for high consequence pathogens. And then our learning objective would be to resolve the complexities of performing clinical trials in biocontainment and barrier nursing environments under good clinical practices. And finally, our last identified need was just data collection challenges when conducting clinical research in these biocontainment and barrier environments. And our desired result is to really have a better understanding or a better preparation of clinical research and regulatory community on the challenges. And our learning objective, then, we really want to experience the conduct of these clinical research trials in a mock biocontainment environment while folks are wearing the high-level PPE. And we did this in the non-clinical course where we actually provided the background education, and then we did mock education. We went into a mock BSL-4 laboratory, and this didactic section was very popular. It had very high evaluation marks. And so we decided we should do this in the clinical field as well, so folks actually have a chance to practice what they learned. And then we would do a debrief afterwards to talk about what went well, what they learned, what they could improve then moving forward. Some of the emerging topics and then the title of our course emerged. And so the title of our clinical course is Achieving Data Quality and Integrity in Clinical Trials Involving High Consequence Pathogens. And as I talk about high consequence pathogens, I realized maybe I should really put a definition up here to share with everyone. So I pulled it from CDC, and you'll see that at the bottom. And we really mean the highly lethal viral, bacterial, prion, and related infections and diseases of unknown origin. And I've listed some examples there. But the CDC also includes infectious diseases that have epidemic or pandemic potential and spread rapidly throughout a population within a short time, or an ongoing public health concern in both industrialized and developing countries, as we see playing out now with SARS-CoV-2. So these are some of the emerging topics that are included now in our course. Obviously, we talk about the Ebola setting because we have a lot of lessons learned there, as we saw in the Prevail 1 and 2. The roles and responsibilities of IRB, particularly centralized IRBs for conducting these studies. Operationalizing a protocol is really important because a lot of these protocols are designed in industrialized countries, but then they're operationalized in developing countries, and there's a significant difference. So how you actually go about that takes a lot of skill and expertise and quick thinking on the ground. Protocol-derived data versus clinical data is a big gap we learned through our stakeholders meeting. Obviously, the PPE that's required for biocontainment activity and barrier nursing and how that impacts data collection. The varied roles of human and animal efficacy data for medical countermeasure development. We found that there is a gap, a knowledge gap there of clinicians and medical staff on what happens in these animal rule studies and how those clinical research trial protocols are designed based off of those. So it's really helpful if they have a baseline knowledge of that, so they understand why the protocols are developed in certain ways. So we talk about that, reporting adverse events, biological sample collection, an overview of GCP, of course, good documentation practices, writing effective SOPs, particularly in these field studies, regulatory requirements. Study monitoring is very important, especially as we're talking about in the middle of a pandemic and how you would monitor those efficiently. Cultural and language barriers is a big one. International issues. So we have international experts that address that. Our lessons learned, of course, and then developing and implementing effective training. And by this, I mean, especially as we're operationalizing a protocol. And so that means involving the local community that's actually supporting these clinical trials and the follow-up of the patients. So our pilot course we held in April of 2019. We had an advisory committee of subject matter experts that really helped us with this course. We had representatives from our continuing education offices, both for physicians and nursing, and our attendees represented the target audience. So we cast a very broad net here so that we can cross-educate as we do the course. So you'll see we target actually physicians and scientists, principal investigators, research physician assistants, nurse practitioners, nurses, pharmacists, clinical laboratorians, clinical research staff, regulators, policymakers, regulatory reviewers are important, biosafety professionals, IRB professionals, sponsors, just to name a few. And then we did actually include a didactic section, which was proper use of the PPE and mock biocontainment barrier nursing scenarios. And our faculty for that actually were from the FDA, CDC, NIH, UTMB, and the University of Nebraska Medical Center. We actually did do a knowledge gain measurement. We did a pre and post course knowledge assessment of those who attended. We distributed 16 questions. Those questions were developed by our faculty members. They were distributed anonymously before and after. And then we actually did a paired t-test to compare. Our response rates pre and post were 82.5% and 70% respectively. The collective average pre and post scores of these exams were 70% and 83%. And that gave us a p-value of 0.0045, which actually did indicate the overall difference in test scores was significant. So we actually did measure an overall average knowledge gain. So our 2020 course schedule then was to do the non-clinical course for maximum containment laboratories. In April of 2020, we always hold these at the National Institutes of Health in Bethesda, Maryland. And then course 2 was scheduled for our clinical course to occur this year in July. And then SARS-CoV-2 happened. So it actually postponed our non-clinical course. And then actually what happened to our clinical course was we've actually postponed that, but we are on target to host that in October, the 26th through the 31st. But our lectures will be virtually, they'll be live via WebEx, but they'll be virtual. So we won't put a lot of people in a classroom, but we still will do the didactic at the brand new training center in Nebraska, and we will hold very small sessions to do that so we can maintain the safety of our attendees and our training staff. So then we hosted a virtual panel discussion in August while folks are waiting to take that course. And the overall objectives of that was to describe challenges of initiating a clinical research study during a global pandemic. So we brought in the COVID-19 and how we're dealing with that, and to identify potential solutions to improve the conduct of these clinical research studies, which are ongoing now. We asked each of our faculty members that were participating in the panel session to describe their role in the COVID-19 pandemic, share some challenges and solutions of how clinical research studies are planned and implemented during the pandemic, and also be able to share some lessons learned and some closing thoughts. And they were very honest about this. These were our panelists. We had actually Captain John Eckert from the United States Public Health Service, Dr. Chris Cradaville from the University of Nebraska Medical Center, Dr. Susan McClellan from UTMB, who's the medical director of our Biocontainment Treatment Center here. We had Mr. Kevin Barrett from NIH, and I have to give a huge shout out to Kevin because he brings a lot of expertise. He was involved in those Prevail 1 and 2 studies and the implementation of those Ebola vaccine trials in Liberia. So he brings a lot of practical knowledge to the course. And then Dr. John Concado, who's the Deputy Director of FDA CDER, Office of Medical Policy Initiatives. And this was recorded, and we had about 120 people participate. And for those of you that are listening and are from FDA, this is posted internally to FDA. So if you need to know where that link is, just send me an email. This is not publicly available, but it is available to our FDA colleagues. Some of the general notes that I actually took from this were that preparedness for clinical care does not necessarily equate preparedness for research. We must not discount the mental health of our medical and research team. That is an incredibly important component of doing clinical research trials. The lessons learned from our research clinical trials in West Africa, such as Prevail, were very applicable in running the research clinical trials in the United States. There is an FDA guidance document on the conduct of research clinical trials during COVID-19, and I've included the title here so that you can look that up if you're not aware of that. Teamwork and communication are critical. The infrastructure considerations are varied And you kind of have to do your own internal gap analysis before you conduct those. The University of Nebraska actually did a pre-preparedness exercise because they did have a patient surge from patients from the Diamond Princess. We did have one particular sharing of a biorepository that was stood up for a specimen bank so that we could continue to study these. And then, of course, the lack of PPEs that every site is dealing with. So these were some of the knowledge outcomes and the topics that were shared by the panelists. So in closing, I want to really talk about the future. We are planning to hold our course in October. We are establishing dates for both non-clinical and clinical courses for 2021. We're developing an online GCP course specifically to barrier nursing, engaging our subject matter experts who have been doing this. And we're actually developing a graduate certificate program here at UTMB. We did a survey of 2019 attendees, and we had an 88-89% interest in actually developing a graduate certificate program. So we have a tentative title for that. The attendees would need to take both of the courses. There would be tuition fees associated if you wanted to actually earn the graduate certificate. There are no registration fees if you don't want to take that graduate certificate program. So we're hoping to stand that up in 2021. My overall quick closing thoughts are that our overall program educational goal really is to cross-educate our scientific, medical, and regulatory community on how to advance medical countermeasure development and approval. Our focus for the overall program is really on the quality and integrity of the data in these maximum containment, high containment, and barrier nursing environment. The conduct of the studies in these environments has an additional level of complexity. We do offer continuing education units for physicians and nurses at no charge. These are eligible for SQA RQAP credits. And we have had quality assurance professionals take these and claim those credits. There are no registration fees. There are limited seating, so if you want to express your interest, there's an email there you can send, and then we extend registration by invitation. But you can send your interest and we put you on a wait list, and then everybody gets admitted at some point, we hope. There's some additional references there, so there is a published article, particularly in how we approach the non-clinical, that Prevail 1 conventional wisdom article that I spoke to earlier. Some websites from the FDA and UTMB are also listed here. I would be remiss if I didn't do a thank you for all of the folks that were involved, and these are just the broad community that were involved in the development of our clinical course. Likewise, there's also a broad one for the development of the program as a whole and the non-clinical. Shout out to all of those that are here, and I don't have time to list them all or to say them by name, but specifically in blue, my co-director or co-principal investigator, Dr. Trevor Brazel, Dr. Jay McCowan, who's our program manager and makes sure all the inner workings happen behind the scenes for the program, Dr. Christopher Cradaville at University of Nebraska, who's our principal collaborator for us and engages with NETEC, Mr. Kevin Barrett at NIH, who I mentioned earlier, and finally, Rear Admiral Estella Jones at the FDA Office of Counterterrorism and Emerging Threats. This was really her idea in the beginning, along with Dr. Pam Chamberlain, and she is and continues to be our program officer. And there's a little picture of the FDA, UTMB, and Nebraska crew when we did our preliminary site visit to that brand new training facility in Nebraska. And so with that, I'd like to thank you. I'm out of time, and forgive my stumbling over words as I continue to do this through sharing my screen and a little bit of the technology glitches. But I'm really happy that you joined me, and thank you so much. And good luck, everyone. Stay safe. Bye-bye.
Good afternoon and welcome to Data Integrity Validation. I remember taking my first time management course from Steve Covey's organization. The instructor was blunt but helpful. He stated, "This course may not be for you." I thought about that a lot ever since. which brings me to Stephen Covey's quote, "Begin with an end in mind." Computer system validation and data integrity principles actually go hand in hand. However, we had to have some regulatory authorities remind us the importance of data integrity by issuing guidance documents when in fact we are already incorporating data integrity principles into our processes. So let's get started with Stephen Covey's quote. We want to be compliant with both data integrity and validation requirements. I want to lay out a pathway where you can achieve both for the price of one. By starting at the end, number 4, we want to deploy a data integrity compliant computerized system. But to execute that objective, we must need to, number 3, train our staff. However, before we can train our staff, we need to test our computerized system. In order for us to test our computerized system, we must have requirements, business process requirements, applicable regulatory requirements, and data integrity requirements. Let's review laboratory notebook training from the National Institutes of Health and the University of Texas. NIT published these basic principles and best practices on keeping laboratory notebooks. Look at item number 3. It is a legal document. Look at item number 1. It is a complete record of procedures. NIH continues to outline the types of laboratory notebooks: bound, loose leaf, electronic. Now take a look at the advantages and disadvantages of each. I've circled 3. Bound notebooks cannot lose pages very easily. Loose leaf notebooks could have sheets fall out and therefore make it difficult to authenticate. Electronic notebooks require security measures to gain access and require specific compatible software. What I liked about researching laboratory notebooks, again, was the information presented on ethics. Just review the main headings. All data goes into notebooks. No pages come out. Correct mistakes, do not remove them. Honesty is the best policy, which I believe our parents told us time and time again. Let's move to the University of Texas. This is a good example of page numbers, dates, and legible writing. Continuing with the same example, locate the single strike-through line on this page, preventing additional information. Notice that the researcher signed and dated his entry, and there is a valid countersignature. This is an example of proper use and documentation of a laboratory notebook, showing the principles of data integrity. Our pathway to data integrity validation will begin with a survey to start your data integrity process, a review of data integrity guidance documents from MHRA and FDA, and we'll end with key events in validation management and data integrity controls. So let's start with this survey. I'll read each question and you record your answer. This is how you'll score your answers. A yes is equal to 3 points. A no is equal to -1. And I don't know is equal to 0. Now, I will not be asking you to share your results with us, but you can use this as an indication of your level of data integrity validation compliance. Number 1, Does your computerized system have data integrity requirements? Number 2, does your computerized system audit trail meet Part 11? Number 3, does your computerized system audit trail meet data integrity controls such as access, reporting, monitoring? Number 4, does your computerized systems control user privileges, that is, assigned to specific roles and tasks? Number 5, does your computerized system validation SOP require data integrity controls and Part 11 technical requirements? Number 6, do you train all your users on data integrity controls and Part 11 requirements? Number 7, do you have a written and approved data integrity SOP? Number 8, do you have a documented backup and recovery plan? Number 9, do you practice your recovery plan and have documentation of each event? Number 10, did the IT and business owners of the computerized system execute the plan? Now calculate your score. If your score was 30, that's great. And remember, compliance never ends. If your score was 25 to 29, that's good. However, you can do better. If your score was 20 to 24, this indicates you understand validation and data integrity principles, but requires additional efforts to be compliant. If your score was less than 19, you'll need help to be compliant. I hope this little survey helps you understand what is needed for data integrity compliance. Let's move to the guidance documents, starting with MHRA's definitions of data integrity. This can be easily summed up by these 3 words: complete, consistent, and accurate. You may have heard of them before. Also, MHRA points to additional definition, data governance, being the sum total of measures, and data lifecycle, the latter term, which isn't a new term for us. MHRA introduced 2 new terms: static data and dynamic data. The former could be a bound laboratory notebook or a flat PDF file. The latter is an electronic record where one could interact with the data. MHRA's definition of audit trail is a process, while FDA states specific elements. Both are correct. Both ensure that all changes are recorded and that the user should not have the ability to disengage the audit trail in a regulated computerized system. These 2 definitions solidify your implementation process prior to rolling out your computerized system into production. Notice the difference between archived and backed up data. Archived data is long-term permanent retention of data, while backed up data is a copy of current data maintained for the purpose of disaster recovery. FDA's approach to data integrity is a simple reminder that data integrity principles are already clearly listed in the predicate rules. Here are some examples. Data are to be backed up. Data are to be stored to prevent loss. Data are to be documented at the time of collection. Data must be scientifically sound. Nothing new here. The guidance is just a reminder of what FDA has been expecting from us all along. FDA's guidance document continues with original data, true copies that can be checked, verified, and reviewed. Here is FDA 7-question survey. Are data integrity controls in place? Are data integrity activities documented? Are data and integrity activities attributed to a specific individual? Can only authorized individuals make changes? Are changes recorded? Are records reviewed for accuracy, completeness, and compliance? Are data maintained securely from creation throughout its retention period? We are all familiar with the principles of ALCOA, and we are reminded of what good documentation practices require. You have already been aware of these requirements for some time. So let's begin with data integrity validation. This is the balance point. It is a single concept of ensuring validation management and data integrity controls are working together throughout the system lifecycle. Each item in the document is a key necessity for compliance. Remember this document when you need to validate your next computerized system. This is a recommended process for data integrity validation. Keys for success are: get the requirements right the first time, establish an implementation plan to drive data integrity controls, and prepare a commissioning memo for management verification. This slide depicts everything you'll need for requirements management and implementation plan preparation. You'll notice that there are SOPs and training sessions to be prepared and executed before your computerized system goes into production. This list does not include the business and functional requirements of the computerized system, but focuses on data integrity requirements and procedures needed for compliance. For example, ensure the admin staff has restricted access and kept to a minimum number. Align training with these requirements. When we plan for a validation event, we must ensure all requirements are clear, concise, complete, traceable, and testable. Test cases can prove you're meeting your data integrity requirements, that is, audit trails and metadata. Your traceability matrix is current, showing the links between requirements and test scripts. Executing your test scripts should contain the right amount of objective evidence. And the validation summary report states the computerized system is ready for deployment. This is a listing of the data integrity controls that must be in place before your computerized system is placed into production. All are required. I'd like to focus on these two requirements. Login standards. You must have SOPs or standards for user authentication, user authorization, authorized access privileges, password control, and the location of the validation deliverables. Both of these are important, but may have been overlooked in the past. The implementation plan may be new to some of you, or you may have called it something else. This is a key document in the system lifecycle. It requires IT and business owners to sign and approve it, thus making them accountable for data integrity validation and the balance point. It should be reviewed by QA. It contains evidence that must be placed before a computerized system can go into production. Just review the 3 previous slides. Finally, it should be reviewed and updated annually. The commissioning memo is another key document in data integrity validation. It also guarantees to management that the computerized system is fit for use. It guarantees to management the staff has been trained. It guarantees to management that all data integrity controls are in place per the implementation plan, and it identifies the location of all the validation deliverables. What did we learn today? A reminder of what a laboratory notebook has taught us. We took a survey to evaluate our level of compliance on data integrity validation. We refreshed our knowledge of MHRA and FDA's data integrity requirements. You were introduced to the balance point, a new way of looking into validation management and data integrity controls, which can be incorporated into a revised system lifecycle. You were presented with the requirements needed to meet data integrity principles. You were introduced to the implementation plan, and finally, you saw the four main objectives of the commissioning memo. Data integrity is the addition of activities that may have been conducted by separate organizations. However, today you have learned, just with a little effort and small changes in your documentation, that the validation of a computerized system can also incorporate data integrity controls via the requirements management process and the implementation plan. And I'll guarantee you that it will save you time, effort, and money. When will you start using requirements document to include data integrity controls? When will you start using an implementation plan to validate that your data integrity controls are in place? And when will you start using a commissioning memo, which provides evidence of training, location of validation deliverables, and a computer that is fit for use? Thank you, and I look forward to your questions and comments.